So thank you very much. I'm delighted to have been invited to speak to you. What I've been asked to show is a little bit about the personalised medicine that we actually have in action in my clinical area. As my slide shows here, I'm in many ways two things. I'm a practicing clinician, so I'm a medical oncologist. I'm a chemotherapy deliverer to women with gynecological cancer. And then for reasons which will become apparent, I think, as I talk, I've also recently taken up the role as the Chief Clinical Information Officer in the Trust. So if I was required to summarise my talk in one slide, I think that this would probably be my slide. So I would always argue that throughout the whole of my medical career, that if I wish to deliver high quality care, I actually need high quality information. And the better the quality of the information that I have, the better the quality of the care that I need. And so the natural extension of that is that if I want to deliver truly excellent personalised care, then I need really extraordinary information. And actually I would make a paradigm shift here and say we actually need next generation informatics. So what is the greatest obstruction to the delivery and adoption of personalised medicine? Well, it's these. And these are the paper-based case notes that are put on the desks of clinicians as they meet patients. And it is truly fabulous that we have Leeds Omics. But what my greatest fear would be is that Leeds Omics develops a 5-page report that gets filed somewhere in that, because that is essentially useless and of no value to a practicing clinician. So what is of course needed is a digital version of that, a digital care record, and what I'll show in a little bit is an integrated care record that crosses the whole health and social care spectrum. So this is a journey that we began a long time ago. In 2001, cancer registration changed. Instead of just a date and a tumour site, so Mrs. Smith had got breast cancer on the 1st of May, they introduced the idea of 20 coded fields that we needed to capture on each patient. So we need somewhere to collect that data, and after a number of failed attempts using Excel spreadsheets, we actually realised we needed to build a formal database. And we built a system that has become known as PPM, which enabled us to collect that national data set. But we built that up by integrating data. So on the left-hand side here are all the data sources that have been pulled in from all the electronic information sources in the Trust into this single electronic record to essentially create a cancer record for patients. So PPM became the cancer record, not just in Leeds, but across the whole of Yorkshire. By 2013, we got to somewhere in the region of 800,000 patients. We got 250,000 cancer patients in there. And amazingly, for a system that we didn't actually ask anyone else to use, we'd reached 4,000 users. So we have then made a decision within the Trust that PPM will form the basis of a trust-wide electronic patient record. And over the last 3 years, we have worked with a number of academic and commercial organisations to extend PPM now onto a web platform. And rather than just taking patients under the care or referred to oncology, we've now got every patient in there. So we're currently hovering around 2.5 million patients. We're up to about 4 million diagnosis events. And the 5,000 users is actually closer to 6,000 users now. And we continue to hoover in all of the electronic data that is available on all of our patients. And that begins to enable us to change something. And what it changes is what I would put here as the old-fashioned way of seeing healthcare, with the patient stuck at home and me sitting within the hospital and the GP sitting between us, and then these very vague and loose associations between other specialists at the hospital but acknowledged links to the university. And what we realised we needed to change was this central relationship between what I would argue are the 3 experts in any patient. And that's the hospital, the primary care, and the ultimate expert in the patient, who is the patient. So to bring those organisations together, we extended PPM to what is now known as the Leeds Care Record. So Leeds Teaching Hospitals now just becomes one source of information. The 3 primary care commissioning groups become 3 other primary care suppliers, but we have also brought in data from the Mental Health Trust, the Community Healthcare Trust, from the council, so we've got social care data. And we have now got data flowing live, so this is a screenshot from my hospital record. If I see a patient and with the approval of the patient, I can now do a direct pull from the GP system and pull information regarding diagnoses, medication, allergies directly from the primary care record. And just recently, and as a first in UK, we're now pulling live data from the mental health system, and we're very close to going live with the social care and community care data. So the question then is, how can we extend that record to the third member of that triad? And what we need to do is we need to extend our record to the patient. And we are challenged to do that by national policy. So there is a national requirement to have patient access to hospital records by 2020, but that is very much seen as just a passive viewer of their hospital record. And I would want us to go further and make them not only just a passive viewer, but an active contributor to their record. And we're just beginning to explore. We've reviewed our ability to do this ourselves. There are immense security and governance issues in this area. And Cancer Research UK have just approached us. Would we be willing to take part in a collaboration with a commercial organisation, but interestingly, a commercial organisation that began as a Cambridge clinicians project to set up a patient portal. And so what we're looking to do is see if there's a mechanism by which we can fire data from our integrated care record into a platform which patients can then use to access their own record, access their own data, and more importantly, can begin to send us data back from themselves at home, and a platform here for video conferencing, so we no longer require patients to actually come to the hospital to have the consultation. So PPM and the Leeds Care Record is then very much what I would argue is the platform upon which we can develop personalised medicine. And so what I will now show is a number of projects that we're running within oncology which move towards that. And some of those projects, I think it's fair to say, have happened or are only possible in Leeds because we have PPM and the Leeds Care Record. So I'm a chemotherapy specialist. I've spent much of my professional life doing clinical trials of chemotherapy. And this is one of the classic trials that made a number of people pause, because this was a massive international collaboration. It was a 4,300 patient clinical trial. I think there was something in the order of 60 countries involved, 5 different chemotherapy regimens to work out which was the best way of treating ovarian cancer. And it's the most negative study I have ever seen. So there are 5 lines here, but they are absolutely impossible to distinguish. And I would therefore argue that unless we invent a new and very different chemotherapy drug, we've probably peaked with chemotherapy efficacy. And the world has of course changed. And the world has of course changed towards new targeted therapy. So rather than treating people with what is essentially intravenous domestos, designed to kill actively dividing cells, we're now moving towards targeted therapy. But targeted therapy that is only given to a minority of patients, and a minority of patients who have the particular phenotype, which means that they will respond. And here is now a classic example. This is the key study of a new class of compounds, the PARP inhibitors in ovarian cancer, in which patients with ovarian cancer, once they've received chemotherapy, go into a tablet, and you can see now the very significant difference between these two arms. For those used to looking at clinical trial hazard ratios, this is a hazard ratio of 0.18, which is an extraordinarily positive trial in oncology. But the group of patients who are benefiting here are the patients who have the BRCA gene mutation. And so what we need to do is start testing patients in a way that we hadn't historically done that. So we have, on the back of, this is very much just in the standard NHS, the NHS commissioning field, we have now introduced routine BRCA gene testing to all women with ovarian cancer. We're identifying 15 to 20% of patients who have this gene abnormality, and it is those 15 to 20% of patients who will receive this therapy and therefore are likely to achieve the benefit. So that is routine NHS molecular profiling, but the technologies have moved beyond this, and this is a collaboration that we have established with a company in North America, Caris Life Sciences, a company which is able to do advanced molecular profiling. So rather than looking at one gene, this is now looking at 592 genes on a tumour sample. And we made contact with this company, and when they became aware of the quality of clinical data that we held in Leeds, they asked us whether we'd partner them in a grant application to the Innovation Fund to have a look at the Caris profile on the tumour samples that we had taken in many of our patients. And this trial has taken a little while to set up, but we are now actively recruiting and beginning to see the advantages. So here is one of my patients going through. Here is the routine NHS result that we have now from NHS commissioning, in which we're looking for this BRCA gene test. And this lady is negative. So this lady does not have the BRCA gene test in her blood. So off we sent her tumour to Caris, and they can now classify all of the chemotherapy drugs that we give into good and bad. But what was interesting is they actually said PARP inhibitors were good. And the reason they said PARP inhibitors were good is this lady's tumour has the BRCA mutation, not her germline. So she didn't inherit a BRCA gene mutation, she acquired a BRCA gene mutation. Now that gene testing is currently not happening in the NHS, and what we're struggling with is what is the commissioning route to get that service delivered to our patients, because the drug is NICE funded for these patients. So the last project I'll talk about is a project that we've established with Philips Healthcare, and is a really intriguing personalised medicine solution. This is personalised medicine that allows us to stop the patient coming to hospital and actually to keep the patient at home. It's a solution to one of our major clinical problems when we give chemotherapy. So we destroy a patient's resistance to infection. We drop their white blood cell count. If a patient develops a temperature on chemotherapy, it's essentially a medical emergency. It's a blue light ambulance, and the patient has to come to hospital where they have a blood test done. And if their blood counts are low, they are admitted and they get antibiotics. And if their blood counts are not low, we send them home. But we are a regional service, so we often ask patients to drive to us from Scarborough to have their blood test, to be told they're fine, and therefore they can go home. And also what we do is we have to do a blood test before we give the next cycle of chemotherapy. So once they've come in mid-cycle and gone home, they then come back to us 10 days later for the next cycle to once again find their blood count is low, and hence once again they have to drive home. So we were approached by Philips, who had developed this device, which is a consumer device about the size of a toaster or a kettle, which can now do a blood count on a pinprick of blood. So this is exactly like diabetic monitoring, but rather than just a blood glucose, this is now the blood count that guides our treatment. So we now have the ability to allow patients to manage themselves at home with a device that can do their blood count, which on a touch screen they can answer questions about their symptoms, a Bluetooth thermometer to fire a temperature to us, fully integrated within our care record. So we did a piece of work with them, Mike has alluded to this, where we looked at the pathway that we knew our patients followed, where we gave them 6 cycles of chemotherapy. They always phoned us if they had problems. And we actually identified that patients followed not an infinite variety of pathways, but of 560 patients who went through with breast cancer and one particular chemotherapy, they actually followed about 490 different pathways of care. And that is the complexity that means that we need the staffing levels and whatever. And what we need to do is put the patient in charge of that by giving them the technology in their house. So with some additional funding from a KTP program, we developed a predictive model. and then are just waiting to start a clinical trial assessing the clinical utility of this device. So we will give this device to patients who are having chemotherapy. We will ask them to record their symptoms, their temperature, but also to do a blood count. What's almost never been done with chemotherapy is to do a blood count every day. And of course we don't do that because we would have to ask the patient to come to hospital, but this is a 3-minute test that can be done in the kitchen while they're having a cup of tea. So we have the ability to radically change the way we deliver the care of these patients. So if we see a patient who perhaps on day 5 their blood counts are dropping calamitously, we can see if we can actually stop the event occurring that leads to the acute admission. So we can give them drugs to stop the infection developing it. For some chemotherapy regimens, we already do that. So we know that there are chemotherapy regimens that have a 20% risk of admission. So we give this drug to everybody. But that means we're wasting that drug 80% of the time. And the question is, can we identify the 20% of patients who truly need it by doing blood tests at home on perhaps days 3, 5 and 7? Can we keep patients at home who have a temperature but their counts are fine? So at the moment, we sort of feel guilty for getting the patient to travel, so we just admit them to hospital. And if that happens to be on a Friday, we historically, and we're looking at a vet, I must reassure her we've stopped this, you would find those patients in hospital 3 days later. So the patient had actually arrived, been admitted for a problem they didn't really have, but not discharged over the weekend. And actually, can we truly change the way we manage these patients? So if the patient truly is sick and really needs antibiotics, well, could those antibiotics be started by the paramedics? And then actually, could a community antibiotic team treat them with those antibiotics and keep the patient at home? So I'll draw this to a close and say once again that I think what we have is an opportunity in Leeds, and I hope I've demonstrated some examples of really coming up with new models of care. But I come from a biased position, of course, and that is those new models of care have to be underpinned by these next generation informatics. And at the seat of that is this integrated care record. Thank you very much.